Actually is, and specific topics like can't really see it. I thought it was up, but our mission is to expand the knowledge base of student pharmacists through the creation of a seminar series to address the need that pharmacy school really doesn't fill. So for the future, we'll use your feedback. I really appreciate the feedback you gave, and we'll bring in pharmacists to talk about specific topics that are relevant to you. And for the future, we're going to have webinars using GoToMeeting, which we're actually testing out today, for pharmacists that are unable to come in person because I think geographically it's a huge problem, and I think there's a huge knowledge base that we can't tap into just because logistically they can't come in person. So we're working on bringing pharmacists that are relevant to you, and even if they can't come in person, they can give a webinar and we'll record it, and you guys can do it in the future. All right, and I'd like to invite Dr. Cooke up to the front or in the back.
Speak in the back too, right?
Sure, that's fine.
One thing, I'm very loud, right? So I should probably work in geriatrics. But I won't do that. So today is really informal. I didn't prepare a lecture to go through slides because of, you guys have that all the time from class, right? So tonight is really to talk about a little bit about managed care, just kind of find what you're interested in, if I can kind of share some of my experiences, and then I think the other big thing is to build for future seminars. If you want to hear about this topic, but we find that right person that gets that information to you, because I think that in terms of kind of having the connections to industry and pharmaceutical companies, this school probably doesn't have those as much as other schools maybe in the Northeast where a lot of the drug companies are located. So let me just show of hands, P1s, okay, P2, 3, and P4. Nobody, they're out on rotation, right, saving lives already. So I guess in terms of managed care, what do you guys know about managed care? What is managed care? Why are we even talking about
it? Is it population health?
So it's interesting. Is it population health? It may be tied to population health, right? But in the old days, what happened when somebody got sick? I'm talking like let's say the 19th. What happened when somebody got sick? They went to the doctor, right? How'd they pay for it? Back in the day. What'd they do? Out of pocket. They bought some chickens, maybe. Oh yeah. Right? They maybe trade some things because people didn't have money. But that's what happened. When somebody was sick, they went and accessed the care that they could access. There weren't a lot to access, and then they paid in whatever way that they could pay. Well, what happened is over time they realized that people couldn't afford to pay, right? And so insurance companies started. And so insurance companies said, because it's a business, right? If I get 100 people and I charge you each, and I'm making these numbers up, but I charge you each $100 a month, right? And then only one of you gets sick. I have, let's say there's, let's say I charge you $1, right? So I have 100 lives. I charge you $1. That's $100, right? One person gets sick and it only costs $20. I just, as the insurance company, has pocketed $80, right? But then I spread risk. So maybe everybody could afford that $1, right? But that one person that needed that $20 for healthcare couldn't have afforded that. So that really kind of is what happened, in terms of insurance. So insurance came, and what they did is enabled kind of the risk to spread among a lot of people, and to provide coverage for medical costs. Well, then what happens, right? So then a lot of people start getting insurance, and it's not just the one person needing it, right? 50 people are needing it, and still up until maybe, you know, I mean, there's been models like in the 1800s, late 1800s, actually managed care models, but people don't really, like building the Hoover Dam, they actually had a managed care type model or a, you know, or an insurance type model, but, you know, but up until probably the last, you know, 2 or 3 decades, it was still the traditional thing. I paid my money to the thing, I went and accessed my care, and my company reimbursed. And then they started to decide what they maybe would reimburse or what they wouldn't reimburse, right? So they said, you know what, I'm not going to Medicare says that if you're, you know, 70 and you want a cholesterol panel, forget it. I'm not paying for it. Maybe you can have one every 5 years, right? So what has evolved over time is insurers, you know, first they were just, you know, they're spreading the risk, right? So they're getting some money to spread the risk, but then over time they're paying for healthcare resources, and then they're getting smart because they're saying, I'm paying for healthcare I have no ability to control, right? So basically the patient or the you know, the insured went and chose when they wanted to access whatever they wanted to access, and the insurer was responsible to pay. So as the insurance market has evolved, they got smarter about figuring out how we control what we pay first, right? So first it was just, you're still accessing who you want to access, you access them when, but instead of the $107 that primary care physician is charging to see you, I'm only going to pay you now a negotiated rate of $75, right? So they started with just changing what they paid for in terms of the dollar amount, and then they started changing things that they started to even cover, right? So they made decisions about coverage. But it's still, you know, I guess you call that managing care, right? So that's really what managed care came. It's that when they started to try to influence the kind of, so if they're just changing what they're paying, that doesn't really influence the kind of care, right? But it is managing care in a way. It's managing the cost of the care. But now as managed care has evolved, and we're in 2016, plans are now incentivizing patients to use certain healthcare resources and to not use other healthcare resources, right? And they do that by financially incentivizing you. Here as an employee, I have to get a wellness, or I get an extra premium, I get a penalty, I get an extra per, you know, premium on that I have to pay out of my pocket. So that's kind of like, they talk about carrots and sticks, right? Are you incentivizing somebody in a nice way, or are you kind of penalizing them if they don't do that? So that's really kind of what managed care is. In a way, it's that the insurance industry has become smarter and sophisticated on how we change the care that you're accessing. And in doing so, you know, when we talk about population health, the hope is that we are changing the care that you access so that we get better outcomes, right? So, I mean, I think the intent is there, but you've got to realize, you know, I think managed care, and I mean, not so much in today's world, I don't know if it's still, but you know, I first started teaching kind of in the 90s, managed care had a very bad name, right? Managed care evil. I don't know if it's still evil or people, you know, have accepted a little bit more, but it was evil because I think they just did price controls and they just restricted coverage, right? So they weren't kind of trying to incentivize and do things. So I think, tell me some examples. So now 2016, what have you guys heard? How is managed care in pharmacy? Why do we talk about this in pharmacy? What are pharmacists doing to managed care? And we'll talk about where they do that, but do you have a thought?
Do they determine the copay of certain medications?
Excellent. So they do copay tiering, right? So that's one way we talk about it. Or it could be co-insurance, right? Or it could be deductible. So we change the structure of how much the patient pays. Now, why would we do that? Why would I change the structure of drugs, of what I make the patient pay?
For certain drugs, well, it depends on you. I don't think you should have the same, every patient pays the same amount, because you don't know who's going to pay what, right? So maybe it's better to have tiers in that way. Don't know. Like you said, it's about, you know, incentives.
Yes.
So maybe you can't afford the brand,
Right.
you know, because the copay is higher there. Maybe the copay is lower with the generic or something.
Yes.
I don't know.
That's true. So copay typically lower with generic. Do you have a thought?
I very well then because we are like lean traders. Like we are the front line against stuff like we're that community pharmacy. We kind of like in a way directly impacted by the decisions of like insurance companies.
Correct. So I think community pharmacists feel, I think, the brunt of decisions that are made on a population level, right? And why I say it's not quite population health, because population health, we're really doing things to help the health of the population. And while we want to do that in managed care, sometimes we're more guided by aspects that may be financially driven versus actually health driven. You know what I mean? But community pharmacists too, because right, like you're there and the claim gets rejected, the drug's not paid for. So I think, community pharmacists, I think, feel the frustration a lot of times and have to deal with it. So that's a good point. Do you have a comment over there?
If possible, could you use the microphone just so that talk for the recorder? Thank you.
I was thinking about like the copay tiers. Maybe it's also if they want to discourage use of brands because they're more expensive, and you probably encourage the use of generics. So the insurance company doesn't have, like, I guess they're not looking at so much. I'm not sure.
Yes. So what you're saying, you're on the right pathway, and that's correct. So in other words, what I do by tiering drugs, which have differential co-payments, right? And there's co-insurance, which is a little different, deductibles, which is different. But what I do is I say, okay, I've got a brand product, right? I now have a generic, an AB rated generic, right? That we consider them, a generic equivalent. I want you to get the generic because I'm going to pay, as a plan, I'm going to pay $5 for the generic and $25, maybe these numbers up, but right, $25. So isn't it better that if I have $25 to spend, I'd rather have 5 people getting each getting a drug than have one person getting a drug. So that's what we've done. And traditionally when we first started, many of the tiering was based on a generic versus brand, right? So it's kind of 2, then we moved to 3. So it was a generic, a brand preferred, and a brand not preferred. So for example, let's say, give me some drugs that you guys know of. I don't want to throw out drug names that you guys, give me some brand drug names. Toprol? Okay, Toprol, metoprolol beta blocker, right? So Toprol is available generically, right? So in other words, let's say when it first came out, when Toprol first came out and there was no generic available, maybe I would have that on tier 2. There's no generic, right? So it's a tier 2 drug, but I would have generic beta blockers, right? Maybe an atenolol. I mean, and I'm not talking about market history, because they probably were similarly, but just pretend that atenolol generic available and Toprol brand only. So I would have atenolol on the generic because I'd want to move people to using that generic. I'd have Toprol because there is no, generic available. I'd have that on tier 2. And then I would have the brand for atenolol on tier 3, right? Because I would I don't want anybody to use the brand atenolol when I've got the generic available because it's AB rated, right? So I really try to disincentivize you from using that brand product when I've got a generic, especially when it's generic equivalent, right? The generic to the Toprol, that's a therapeutic equivalent, right? So a metoprolol and atenolol, they're not the same exact drug, but we consider them therapeutically similar. But the generic atenolol to the brand, that we consider that generically. So that's exactly, so I think in the beginning we kind of did that to try to move people toward less expensive drugs, right? And now we have plans, used to be 2, 3, now we're 5. So you have a preferred generic. There's actually differential pricing in the generic world. So there's, houses that kind of get generics and get better pricing, kind of called MAC generics. So that might be a tier 1, right? A lower cost generic, and then a tier 2 is a generic. Then a tier 3 might be a brand preferred, and then a tier 4 might be a brand not preferred, and then a tier 5 is just sometimes a very expensive therapy that we just kind of don't know what to do with, and we're just charging people a lot of money. Not that we necessarily want to disincentivize them from using it, because oftentimes those products, they're maybe not alternatives, but they're just very expensive. So we look at hepatitis C, which probably isn't on these tier 5, but hepatitis C drugs. So does anyone know the cost of a course? What does the health plan pay for a cost of a course, a 12-week course of a hepatitis C? Give me an idea.
$90,000.
How much, 90,000? Pretty close, right? So I think that's in the ballpark, right? 84 is kind of 80, 84, 90. And again, depending on the plan, what they've negotiated. So one patient, one course, $84,000. So they may put those on a higher tier, you know, and higher tiers could be 100, 125. I mean, the patient's paying very little for the cost of that drug. Did you have a comment? Okay. So I think that's kind of, and so I think the challenge now as we've evolved to where we used to do things based on pricing and generic equivalent, there is we're trying to figure out, now that's kind of looking at pharmacy in a silo, right? So I'm really worried about a pharmacy budget, right? So I'm trying to manage care, manage pharmacy care, manage my pharmacy budget. But what we've come to realize is if I restrict your drug usage, so let's say you really need that tier 3 or tier 5 drug, but I restrict your usage because it costs so much money, what happens? What happens to the patient? Okay, they won't buy it. Good. And then what happens to them if they don't buy it? They get sicker. Right. Because then they'll get sicker, then they might have to go to the hospital, and now I'm paying for a hospitalization one, right? So maybe that's not a smart idea for me to distance, you know, so I think as we've evolved now, you know, we're looking at trying to talk about how we manage the care, the entire care, where we're not incentivizing just to get rid of drugs because now I'm going to pay on the medical, but maybe I want to get you to take the drug so that I can offset the medical. So I think just kind of, you know, globally, we don't want to get too detailed tonight because, you know, you'll be like, oh my God, this is so boring, but you know, I think those are the things when we think about starting with the insurance to managing care to managing pharmacy care. It's really about looking at the entire aspect of that care and how drugs fit into the care plan, not just drugs kind of in and among themselves, kind of with the pharmacy budget. Now, we still have plans. Does anybody know about plans that only worry about pharmacy? About the drug costs? Anybody know any plans that, right?
Pharmacy benefit managers?
Right, so pharmacy benefit, so these are, what's a pharmacy benefit manager or management company, right? What is it?
They're basically the middleman between drug manufacturers and kind of like health plans or hospital systems.
Yes. So oftentimes a health plan, a hospital system contracts with a PBM and they have them manage the pharmacy budget, right? And so they're very, you know, their target is $1, a pharmacy budget. They're negotiating with manufacturers, right? So there's two things to do, right? So the health plan, there's two things they do. One is they change the price structure to change the patient behavior. The other thing they do is they negotiate with the manufacturer to get a better price, right? And there's lots of ways they do that. That's kind of could be a whole lecture in itself of how it could be a rebate, it could be a value-based pay. You know, there's all these different ways to negotiate price. But what the plan says is, like here are, how many lives does our local Blues have? Anybody know? How many pharmacy lives does the local Blues, Blue Cross Blue Shield Care First? Anybody have any idea? About 1 million, 1.2, 1.3 million pharmacy lives, right? Well, let's compare that to United Healthcare. How many lives do they have for medical, or for pharmacy? 33, 36, right? So I think what happens is that I, as a $1 million health plan company, I talk to the manufacturer, right? I go to Pfizer or GlaxoSmithKline, and they're like, you want to negotiate? You got 1 million people, right? They're going to be less inclined to negotiate with me than if I had 33 million people. So what the PBMs have done, if they're getting me, that's 1 million, and Blue Cross Blue Shield of Arkansas, that's 1 million, and you know they're getting all these plans. They then have hundreds of millions of lives that enables them to be a better negotiator. And so what happens is right, that they're kind of the middleman. They're taking their cut to negotiate, and hopefully I, as the plan, I'm getting a better deal. But again, they're very focused on the drug pharmacy budget, right? And so that's one thing that we have to be aware of. The other big thing that's happened in pharmacy, which has really changed the landscape, in my opinion, of pharmacists' roles in providing like MTM, medication therapy management, is Part D, Medicare Part D. So these Part D, the prescription drug plans, the PDPs, they are responsible for the drug spend, drug budget, and not the medical. So you can see there where they're not incentivized to do the right thing. And I'm not saying they're not doing the right thing, right? But they're not incentivized financially because the benefit that they gain from getting people adherent and getting them on the right drugs, they don't see the medical offset. So CMS, Centers for Medicare and Medicaid Services, realized this, right? So that started 2003 Medicare Modernization Act, implemented in 2006. Now in 2015, 2016, they've realized that model doesn't work because they're not incentivized to. So they now have a new program called Enhanced MTM. So it's a program where 5 regions in the U.S. are kind of piloting ways, and if they do things in pharmacy that get better medical, offset the medical, they're going to get rewarded financially. They're kind of trying to look at that, right? So in other words, if I have, here's a perfect thing. If I have patients, I have an elderly population at, risk for osteoporosis, and what are the drugs to treat osteoporosis? You guys know? Bisphosphonate, is that, okay. So, and we're not going into therapy today, but let's say we're going to use bisphosphonate, and there's expired therapy once a year, there's monthly, there's daily, there's weekly. But as a health plan, if I'm only responsible for your costs, what happens if you get, if you don't treat osteoporosis? What are your risks for? Hip fracture, right? Who's paying for the hip fracture? Medical benefit, right? So you're going to the hospital, that's not a good outcome, right? You're going to the rehab, the nursing home. But I, as the pharmacy budget, I'm not paying for those medical costs, right? So I think it's just very important. So I think really when we talk about this kind of locally for us as pharmacists and pharmacy careers, and there's these opportunities now where they're wanting folks that have knowledge to be able to help design these benefits, implement these benefits, design programs around optimizing medication use to really benefit that patient and benefit the medical side of the cost. And I think maybe folks can come in that have programs that are specifically maybe doing some innovative things in that space. But it's that kind of like just as a very general idea of what managed care is and kind of how we're managing care. Anybody have any questions about that?
Is there a good way if you're more kind of clinically oriented that you can kind of still have a career in managed care, like maybe just in general, a couple of different options? So
that's great. I think that managed care, because of Part D, right? Because CMS has mandated, this is the first time nationally, I mean, this is crazy, and I don't know if they stress this in class because it blows my mind away, but this is CMS, Centers for Medicaid and Medicare, told the health plans they need to pay for a comprehensive medication review for every eligible Medicare beneficiary in a Part D plan or a PDP or an MAPD. So this is the first time required. Now, they don't require pharmacists to provide that service, right? But I think the general flavor is that pharmacists, we are the drug experts, we probably do that better than other entities. But for clinical, so I've got plans now, 5 years ago, before they had a little bit of MD, let's say prior to 2006, I guess a decade ago. Nobody, well, there was no Part D, right? But 2006 it started, but none of those plans were really engaging pharmacists. Now, like I got called to help manage the MTM program of a Part D plan. Do you know what I mean? Because now it's mandated. Now you got to do it. And like, for example, I get calls from headcount hunters or things like that. Like 2 years ago, they were opening up a brand new center. They wanted 250 pharmacists to provide MTM for managed care plans. So there's a lot of opportunities, I think, for clinical in managed care, and maybe even more so, to be honest, opportunities than if you don't want to see patients. You know what I mean? The opportunities to kind of manage the pharmacy, I think they're there. But I need 250 pharmacists to manage my 1 million lives, and I may need 5 to 10 pharmacists to decide the policies or to decide the benefit. So the opportunities, I think, are there, and there's lots of companies hiring all the time.
So if you're one of the pharmacists doing the MTM side, what does your schedule look like? Do you have a caseload, like a patient that you follow? Wonder what that's like in that.
It's great. So there's a couple different ways that plans set that up, right? So they have it in-house, where they actually hire you, you're an employee of the health plan. They have vendors in which the health plan contracts with a vendor to deliver, which maybe you may be an employee of the vendor, or there are vendors that the health plan contracts with that actually contract with independents. So so that may be a whole different lecture, in itself, but let me just kind of give you some smattering, right? So some of the folks that work, let's just call the in-house folks, right? They're hired, like a couple of my residents are actually doing MTM in-house for, one is now United, because it was different. It was company A bought by company B, and then United bought them all up, right? So she's doing it for United, another one for Humana. And so they're employees of the health plan, but not only are they doing it because of Part D and the mandate, health plans now say, wow, if this works for my Part D, maybe I need to do this for my commercial, which is not mandated. So we're starting to see that kind of creep out too. But both of them, because they work in-house, they're by the insurer, one of them actually goes to a physical office and telephonic MTM, right? So that there's, you've got a caseload, it comes off the computer, all this stuff. Do you know what I mean? Somebody's scheduling for you, and you're kind of doing the review by phone. The other one works from home, and kind of same thing, telephonic, I think, but I think it has some more flexibility with hours and scheduling. So, like, let's say you wanted to work from 6 to 10 at night, then you could just put your open hours. Somebody schedules for you, right? Because you don't want to take your time scheduling somebody, but you could just put your open block. So I think working at home gives you a little more flexibility in the schedule there. And then a third, where another one of my residents went, is where I actually work in the health plan, but they're in clinics owned by the health plan that see they're either owned by the health plan or they see a large number of their members. So they're seeing kind of like what I call traditional ambulatory care in that market. So kind of very different ways to do that, yeah. And we have here, are you folks familiar with the P3 program here at Maryland? So basically they have where it's an employer. So now, we're talking about health plans, but employers, if you're a self-insured employer, you're at risk, right? The employer's at risk, right? Versus, if I'm giving, like if I'm an employer and I say, okay, Care First, I want you to manage, Care First may be taking on the risk, right? You know what I mean? Like it depends, like I'm just paying you my premium and you better have calculated your numbers right so that, right? Or employers are actually taking on that risk. So they may be, they may still go through Care First, but Care First is just what they call adjudicating. They're just administering it, but like if it's $1,000, that employer pays $1,000. Whereas Care First, it may be, let's say that patient had 1,000, but I, as a university, I've already given you my premiums. If I gave you 900, you're out 100, and if I gave you 1,200, you keep 2, right? But the employer, it's a more direct thing. But basically, the employers are hiring clinical pharmacists, go to the employer sites, and they're performing MTM at the employer offices to see the patients. So lots of different options. And it might be interesting to grab somebody who's actually doing that and have them show you, if they could show you a mock screen, you can't see the patient's data, but just a mock, like what does it look like? What kind of data are they getting? What from the claims, like, because they know your prescription data. I can see the claims that have gone through, what information they get, how do they use it, how are they, talking to them. I mean, that might be an interesting to kind of see. Did you have a question? No? Somebody raise their hand over there. What else? What other questions? Is there anything else burning to? That's okay.
You said you have 3 residents?
Yeah, so I have 3 residents that have gotten through different. I mean, I've actually had 15. I think now I lost track of the numbers. I haven't written down, but I think 3 have been in those tracks. 2 are currently in them, and then 1 left and actually got another job. Working for. No, what do you mean? They did their PharmD training, and then they came here to Maryland to spend a year with me.
Oh.
Yes, and then they went and kind of got jobs, different, places.
Oh, you mean total, like in the span of years you got probably 15?
Yeah, 15, yes.
Oh, okay, I thought you meant at a time. I'm like,
oh, no. Probably like, you get 1, I only take 1 a year. 1 year I took 2, and it was only 1 year I took 2, and then I never took 2 again. So, but I had 1 was actually doing an ambulatory care residency. So she's actually manager of an outpatient oncology center, and then everybody else has been managed care.
I was wondering if you could talk a little bit about integrated healthcare systems. I've heard Kaiser has one, and I've often heard it being referred to as innovative, and why is it innovative?
So that's I think that's interesting. So in the old days, when we used to talk about different models of managed care, right? The first model kind of, like I said, it's building the Hoover Dam, right? It was the late 1800s. And what they realized, somebody would get sick. And then what they would have to get them on a horse, right? Because there were no cars then, and transport them miles and days to the nearest healthcare doctor. They didn't make it a lot of the time, right? There was no preventive care in those days because, we just didn't do preventive care. Nobody really worked. So what the folks that building the Hoover Dam realized, they said, we need to bring medical care here. We need to bring it on site, right? And then they started doing some preventive care, checking people out before that, talking about some safety and some things like that. And what they did, interesting, is they took money out of the workers' paychecks, a very small amount, but took it out. So that's kind of the first of the managing, right? Managing the care, right? I mean, so that model kind of was what they used to call it kind of evolved, a long evolution, right, 100 years, but into what we call the stack model HMO, right? Kind of these Kaisers. And the way I like to refer to them is one-stop shopping. That's actually where I did my training, was up in Delaware. And it wasn't an HMO at the time when I was there, but it was transitioning out of the HMO, so it still looked like I was in a building, X-ray was there, the lab was there, pharmacy was there, pediatrics was there, specialists were there, primary care was there. PT was there. You kind of went to the building and you could have almost anything you needed done, and then across, if you needed a specialist like surgery, you go across the hospital. But really, so these Kaiser models, they have a real ability because they have had all of the data, right? So in other words, all of the stuff that goes on, all of the care for that patient is kind of happening in a central location. So if I need to talk to the cardiologist, unlike traditional practice where my doctor is here and the doctor has to call the cardiologist, and the cardiologist is seeing somebody and you can't get them, I can walk down the hallway and talk to the cardiologist. And so there was a lot of advantage in terms of communication, coordination of care that was very, very difficult. You've got to think, electronic systems, which are just coming into play, are still in their infancy. But there was very little way to, I would see, I was actually, looking at some of my notes, because you have to save them for 7 years and getting rid of some of them from 7 years ago, more than 7 years ago. And they're all handwritten. I did everything by hand. There was no computer at the facility that I was. So the Kaiser model is the one-stop shopping, kind of all the care is there, it's coordinated, everything's electronic. So they really have an ability to identify the patients and their needs, get them addressed, right? And then there's a lot more coordination and communication. The other thing that Kaiser has is they employ their healthcare providers. So Blue Cross Blue Shield, they don't employ healthcare providers, right? They negotiate contracts with those healthcare providers in the community. The Kaiser folks are employed. So how effective do you think it is if I want my doc to not use a COX-2 inhibitor, but to try a generic NSAID before a COX-2 inhibitor? How effective do you think that is for the Kaiser doc? Pretty darn effective, because you don't listen to me, you don't have a job, right? And think about that. So it was much easier to make changes to control behavior and systems in that kind of environment, unlike where I got a doc and he's only got 5 of my members that he's seeing, and he may, maybe 5% of his roster. It's more difficult for that doc, him or he or she, to, if he wants to use a COX-2, and he's not going to be pressurized by me or my 5 people to do that. Does that make sense?
Can I follow up to that?
Yeah.
So for the current healthcare system that we have, that's not systems like Kaiser, electronic health records are an obvious barrier, but what are some other barriers that we're facing now to move in that direction of having coordinated care in that model?
So I think that's great, and I think so electronic records have come a long way, right? And there's now something called e-care planning, which is this new document. There's HL7 architecture that helps to frame up this document so that I see a patient, I can communicate with provider A, B, C, and D, So I think we're getting there, right? And ONC, the Office of the National Coordinator, is working on initiatives, right? Like electronic prescribing was the first one that they require, So we have come a long way. but there still are barriers, right? The other biggest barrier, and this is Cooke talking, right? This is my personal opinion, is that, it's the payment structure, right? So I'm a health plan, right? And who's paying to coordinate care? Is it the doctor? Is it the primary care office that's paying to coordinate care? Is it the hospital that's paying? And Maryland is unique. I don't know if you know, Maryland is unique among the states. We have a waiver program for hospitals and for payment. So our system is different than many other states. But the challenge there is who's paying for that care coordination, right? Who's responsible for that care coordination? So that's the first problem. And then where do you put those care coordinators and who do they listen to? So for example, I worked with a health plan, and this was a great program. And it was a care coordination program, and I worked with care coordinators, and these people were phenomenal. I mean, phenomenal. I can't say enough about the program. I would have issues where I would, like let's say, I or my team of pharmacists would see their drug-related problems or things that need to be corrected. But I'm in my center. I don't have a relationship with the provider that wrote that prescription. I hardly have a relationship with the patient, right? I'm seeing this on claims data or things like that. My care coordinators who had a relationship with the patient and with the health provider, the healthcare provider, could get those changes made. So I think, but the question is, so that the health plan actually paid initially for those care coordinators to be in the primary care offices, because they felt like that's where care coordination should be happening, right? And the hope was that those primary care offices would eventually pay for the care coordinators. Now, some of them have really seen the value of the care coordinators and they employ them on their own, but most of them did not. Because, when you're thinking about a traditional fee-for-service model, which, is still, there's still fee-for-service going on in most of commercial world, which means I see you, I get my, I get my $50 to see you. I see you 2 days later, I get my $50 to see you. I see you 3 days later, I get my $50. So every time that I'm seeing you, I'm getting paid more. When I'm having a care coordinator, I'm not getting paid now. There's no payment. That care coordinator can't bill. There's no payment for that care coordinator. And I may be offsetting medical costs, right? I'm not getting the benefit of that. So I think, to me, that's the biggest barriers. Where's the financial incentives? And again, we're starting to move there. So some of the health plans that I've worked with have incentivized those providers with a pharmacy and a medical spend. So if you do whatever you do, you get a care coordinator, and you are under these thresholds that we've determined, I'm going to give you a $400,000 bonus at the end of the year. So now you're incentivized. It's kind of indirectly though, right? It's not on an individual patient basis. It's on a, kind of an aggregate for that. And we're also seeing that with, kind of what we call these ACO models, accountable care organizations, where they're getting a fee to manage those members, almost like in the old days, like a capitated fee, right? Here's your fee to manage. So then you're incentivized to try to find the best resources to manage those patients in a different way. So to me, though, that's where I think the barrier, EHR, which we're moving along, that's still a barrier of communication, right? But it's also the financial incentive where it's, I'm used to seeing you, and every time I see you, I get more money, and now I want to see you less, and I want to have other people seeing you, and so it's hard. It's easy to relate those dollars, 5 visits, 5 payments. It's hard to see, it's also hard to evaluate and figure out what those best models are that's going to get me the best return on investment, Yeah. And Kaiser may be advantaged when you talk about that model. They've got the, premiums, right? They're controlling all that. So they may have a better ability. They've got the data. They've got better control, and they have an ability to kind of look at the value that they're getting from these care coordination teams. And, we see a lot of pharmacists in Kaiser models, in, kind of, we'll call them clinics for lack of a better word, but integrated, certainly in Colorado, California, and Maryland, I think here, mostly anti-coag and diabetes, but that was where they kind of saw the value of those teams. So I think I probably talked enough. If you guys have any other questions, feel free to email me or whatever. And I think, just to kind of provide some guidance to your folks here of other folks or I know we've talked a lot of stuff, but there's things that you're really interested in, maybe finding, speaker, and I could help too, to get some folks that maybe could, if you want to see the MTM, like maybe somebody could find somebody who had a screen like that, or somebody who's doing, and we didn't even touch on prior, like some of the tools we manage pharmacy care, right? Like utilization management, prior authorization, and pathways and pay for perform, so we might be able to get some of those examples, because sometimes it's easier to see what they're doing on a computer or have an example than just to hear somebody talk for hours. So I appreciate you guys coming, and you want to close out? Okay.
Let's give Dr. Cooke a round of applause. If you guys have any further questions, we'll be around, and thanks for coming, guys.